Thank you, Mary, for the introduction, and thank you, Dr. Rollison, for funding this visit here. I appreciate it. So the outline of my talk today is this. I thought we'd go over just enough background physiology so that we're all on the same page. A little bit about the history of the discovery of FGF23, which I think is very interesting. And then into FGF23 biology and physiology, the diseases of FGF23, and treatments that we have now and that are on the way. But first, I would like to go over this case, which I think will be very illustrative. We'll come back to it at the end. And this was a girl that we saw at the NIH. She was 17 years old. She was from the West Bank. And her problems began at the age of 10 when she had bone pain, weakness, falls. She had multiple fractures. She fractured her wrists twice, both hips, with very poor healing after that. She'd had a normal birth, normal growth, normal height, normal menarche, no signs of bowing, so this did not appear to be some sort of congenital problem that she had. Really unremarkable family history. And she had had multiple evaluations in the West Bank, which you might imagine is not probably ideal. She was eventually, with a lot of difficulty, referred to Rambam Hospital in Haifa. But during this period of time, she really progressed to tremendous debilitation. She could no longer walk. She had to be in a wheelchair. She could really hardly raise her legs from the bed. And it was really only 4 years after the initial presentation or initial evaluation that she was ultimately found to be hypophosphatemic, which is not unusual for patients like this. And we'll come back to that later. Anyway, so that we're all on the same page, and I know that there's people here from the renal division, but most of us are not nephrologists. So, and the mouse that I was going to use as a pointer is gone, but I think someone will bring that back to me, I hope, right? Okay, maybe not. Okay, so anyway, it's interesting physiology. So phosphate is filtered at the glomerulus. Most of it is reabsorbed at the proximal tubules, and then that which isn't reabsorbed is excreted into the urine. And we had known for years that this was under the regulation of parathyroid hormone, that parathyroid hormone inhibited phosphate reabsorption, and that parathyroid hormone resulted in the excretion of phosphate and cyclic AMP into the urine. Then came along, and what we'll talk about here today is FGF23. FGF23 does the same thing. There it is, thanks. Does the same thing that, and this is tricky too, I've got to put it on this screen. Okay, there we are. I don't see it, but anyway. Okay, so FGF23, the topic of the discussion today, does the same thing at the proximal tubule at parathyroid hormone. It causes the excretion of phosphate into the urine, although it doesn't result in the generation of cyclic AMP. The other important thing that this busy cell in the kidney does is generate 125 vitamin D, which is the active form of vitamin D. So 1-alpha hydroxylase converts 25D to 125D, which then goes on to promote calcium absorption and phosphate absorption in the gut, and ultimately raises blood phosphate and calcium. This, too, is under the regulation of parathyroid hormone. It stimulates this process, but here, parathyroid hormone and FGF23 diverge, and FGF23 actually inhibits this process. So FGF23 inhibits 1-alpha hydroxylation and the generation of 125D. And it'll become important to know later who has sort of the upper hand in this process. Is it PTH or is it FGF23? Okay, so now that's enough of the background to get us all on the same page. A little bit about the history, which I think is very interesting. So this is another, within the field of bone and mineral metabolism, Fuller Albright is sort of the god that we all pay homage to. And Fuller Albright was described one of the first cases of what ultimately we know to be an FGF23 disease. And that was this boy that they saw at the Massachusetts General Hospital who had rickets that was resistant to vitamin D therapy. So they called this vitamin D resistant rickets. The boy had a normal blood calcium and really pretty profound hypophosphatemia, and the incredible evidence of rickets and bowing that you can see here. Anyway, most of the cases of this were caused by vitamin D deficiency, which is they thought was probably the case at the time. So this is a figure from that paper where you can see over a period of time they gave escalating doses of vitamin D, escalating to the point where they intoxicated him with vitamin D and made him hypercalcemic, but had really no effect whatsoever on the serum phosphate levels. So nonetheless, what Fuller-Albright thought is that what they called this was vitamin D resistant rickets. And this is one of the few times where Fuller-Albright sort of missed the boat. He really thought that this was still, in fact, the result of parathyroid hormone. And you can see, I'll show you later what with that thinking led to later on. Anyway, so the next step forward in our understanding of FGF23 came from this very nice familial genetic study that was performed in North Carolina, shown here. And this was a large family that had what was called at the time vitamin D resistant rickets. But as they evaluated this family, it was interesting. So what they found is that none of the sons of the affected fathers were affected, but all of the daughters of the affected males were affected. So therefore, this was an X-linked disease. So now we would call this vitamin D resistant rickets X-linked hypophosphatemia. So this was sort of the next step forward in figuring out what this was all about. The next break was good luck, and this was from the Jackson labs, and they discovered this mouse that had spontaneously developed a mutation, and the mouse looked like patients with XL8. They called it the hip mouse, and this was a model for X-linked hypophosphatemia. So, okay, so now we had a mouse model. And then one of the prevailing questions at the time, so was this disease due to a problem in the kidneys, or was this due to a circulating factor, a hormone? Of course, the endocrinologists were rooting for the hormone, and the nephrologists were rooting for the kidney. Anyway, Ralph Meyer did this beautiful set of experiments, these parabiosis experiments, where they took the wild-type mouse and hooked up the circulation of that mouse to the hip mouse. And when they did that, some factor in the blood of the hip mouse now made the normal mouse hypophosphatemic. And when they broke this circulation, the blood phosphate came back up. So this then, and in fact, Mark Dresner after this went on to do renal transplants in these same mice. And again, this confirmed that it was a factor in the blood that was initially called a phosphatonin because it regulated phosphate. So now we have the fact that this is a circulating hormone in the blood that's causing this problem in X-linked hypophosphatemia and in the hip mouse. So fast forward now to 2000, and this is Michael Econ's in the ADHR consortium. So these are families with autosomal dominant hypophosphatemic rickets, and they eventually discovered in this group of families that there was a mutation in this gene that they called FGF23 that was responsible for the hypophosphatemia in these patients. And the speculation at the time was that all the mutations occurred in this area right here. This is the amino acid sequence here. And this amino acid sequence represents a site where proprotein convertases such as furin can break these molecules down. So the thinking was something like this, that intact FGF23 is the active hormone, that mutations in this consensus sequence allows the intact molecule to escape degradation by furin, or to be degraded by furin, I should say. And then what happens is that the serum levels of FGF23 of the inactive N-terminal and C-terminus clips accumulate. So full-length levels of FGF23 accumulate and the disease ensues. Okay, so now we have, at that time, it was a new hormone, and then the question becomes, okay, where does this hormone come from? How is it regulated? What's the biology of this hormone? And then what are the implications from this understanding that we derive for the diseases? And what are the drug targets for the diseases now that we understand this physiology? So this is actually where I became interested and got into this area. We were just studying a group of patients with fibrous dysplasia of bone who can also have elevated levels of FGF23. And we had wondered at the time, too, is the FGF23 in these patients from renal defects or from accumulation of the hormone? And we were able to show that it was accumulations of FGF23 in the blood in these patients that was responsible for it, and that, in fact, the high levels of FGF23 were coming from the dysplastic bone in these patients. We went on to show that it was not only dysplastic bone that made FGF23, but in you and I, who have high levels or measurable levels of FGF23, that normal bone appears to be the source of FGF23. And so this was eventually confirmed by other people, and now this set up our first understanding of this hormone and its pathway, which is shown here. So we have a hormone, FGF23, that's made by bone cells. It circulates, acts at the kidney. Its effects at the kidney are on phosphate reabsorption and 1-alpha hydroxylase stimulation, such that high levels of this hormone can then decrease serum phosphate and decrease serum 125D. So now we know where the hormone comes from, where it's made, and the question becomes now, how is this regulated? Well, this is still an open area of discussion, and there's been a lot of work done here, and there's a lot of work ongoing as well. And what we know to date, to some extent, is that certainly this is regulated to some extent by serum phosphate and by serum levels of 125D. So this would sort of close the feedback loop in a typical classical endocrine feedback. So a little bit more on this, and I'll just quickly go through this. We have learned subsequently, too, that this circulating FGF23 acts at an FGF receptor. It acts at FGF receptor R1. Well, FGF receptors are all over the body, so what gives this hormone its specificity? And what gives it its specificity, it's a really neat system, is this co-receptor Klotho. So this co-receptor Klotho has a very limited tissue distribution expression, so only on tissues that express FGFR1 and Klotho will FGF23 have an action. And so clearly this is the proximal renal tubule cells, the best studied, the best clearly defined. It may be other places as well, but clearly this is the most important part of the FGF23 physiology. Okay, so now back to the question of the similar actions between parathyroid hormone and FGF23 at the kidney. So we have these two hormones, PTH and FGF23, both acting at the kidney to regulate this process here. So it's a bit of a funny system. Why do we have this? Is this redundancy? Is there interaction between these? Is there a hierarchy between these? So this is one of the questions that we asked, and we thought that a nice system to study this in would be patients with hypoparathyroidism, patients who lack PTH. So we did a study in a group of patients with hypoparathyroidism, and I'll walk you through this because it's a little bit tricky. So these were three groups of patients, patients with hypoparathyroidism, hyperparathyroidism, and healthy controls. And we looked at the relationship between FGF23 and blood phosphate in these three groups of patients. And these circles represent the mean and standard deviation in both directions for serum phosphate and serum FGF23. And you can see very clearly that the healthy controls and the hyperparathyroid patients have essentially the same sort of physiology, but these patients with hypoparathyroidism, in spite of having high levels of serum phosphate and high levels of FGF23, that the FGF23 in the absence of parathyroid hormone is ineffective. So this led to the hypothesis that FGF23's phosphaturic action is PTH dependent. This would not only explain the physiology, but also suggest some potential treatments as well. And so we went on to test this in a sort of proof of principle fashion in a couple of patients with tumor-induced osteomalacia. So let me just briefly introduce this disease now. So tumor-induced osteomalacia is a paraneoplastic syndrome of FGF23 excess. And they're these little teeny mesenchymal tumors that can be found anywhere in the body from the head to the toes that make exuberant amounts of FGF23. This leads to fractures, rickets, osteomalacia, etc. So If you can find the tumor and remove it, these patients are cured. But in some patients, it's really hard to find these tumors. So we had a couple of patients who we couldn't find the tumor. They had terrible disease. And with this idea that, in fact, FGF23 action might be PTH dependent, if we decreased PTH in these patients by giving them cinacalcet, could we then affect the FGF23 physiology in these patients and possibly improve their outcome? And that's exactly what we saw. And shown here is the results in one of these patients. So PTH levels were normal, gave them cinacalcet, PTH levels went down, and as a result, phosphate levels came back up into the normal range. The FGF23 levels were still high, and it was able to heal the osteomalacia. So this, in fact, proved to some extent that FGF23 action is PTH dependent, and the second thing that it suggested is that cinacalcet could possibly be an adjuvant therapy for diseases of FGF23 excess. I wanted to return now to this interesting paper by Fuller Albright, and what wasn't appreciated at the time by them in studying this patient, there were actually, over this long period of time, in this very complicated figure here with 1, 2, 3, 4, 5 y-axes and how many years here. Anyway, so this yellow is the normal range for blood calcium. This color, whatever it is the normal range for phosphate. And over the years, there were 3 periods of time where they got this boy's phosphate into the normal range. And they were here, here, and here. And all of those coincided with times when they had made this boy hypoparathyroid. So remember I told you that they thought the cause of his disease was parathyroid hormone. So they did a parathyroidectomy. They put him into tetany for a long period of time and almost killed him. But his phosphate became normal when his parathyroid hormone was gone. And again, these were 2 periods of times where, again, they intoxicated him with vitamin D and lowered his parathyroid hormone. So the writing on the wall of this interaction between parathyroid hormone and, at the time, this unknown factor that was causing this in this boy was evident all the way back to 1937. So I think there really is pretty clear evidence that the action of FGF23 depends on PTH, and this is a potential drug target for these patients. Okay, so we're endocrinologists. If there's a disease of a hormone excess, there's a disease of a hormone deficiency, and the hormone deficiency is another very dramatic disease, which is called familial tumoral calcinosis, and this is a striking example of a patient with this disease here. And so they call it tumoral calcinosis because they can get these huge masses of calcific tissue here, which is calcium phosphate hydroxyapatite. They can get calcification of here, they can get calcification of the blood vessels, the gut, etc., etc. And the cause of this disease is FGF23 deficiency. So these patients have very low levels of FGF23. Because their FGF23 is low, their phosphate is high, the calcium is normal, the 120 of 5D is inappropriately normal. But what happens with these patients, and what's believed to be one of the major contributors to the ectopic calcification that they get, is a high calcium phosphate product, which is shown here. Probably this isn't all of the story, because as our nephrologists will show or confirm, many of the renal failure patients have calcium phosphate products that are this high, but they don't develop this tremendous ectopic calcification. So certainly this is what contributes to it. The underlying pathophysiology is a deficiency of intact FGF23. So how does this happen? Well, in most of the patients, it happens this way. That these patients have a mutation in this enzyme, gallant T3. So gallant T3 is a galactosyl transferase. It glycosylates FGF23. And when FGF23 is glycosylated, it escapes degradation by this proprotein convertase, and you have intact FGF23, and everything is great. But if you have mutations in FGF23, in gallant T3, then it's not glycosylated. It's open to degradation by this proprotein convertase, and you have circulating in the blood high levels of the the clips of FGF23, but relatively low level or absent levels of intact FGF23. So that's the nature of that. And it also says, though, then that now post-translational modification is potentially a locus for the regulation of biologically active FGF23. And in fact, that does appear to be the case. This was a very nice study, again, in patients with autosomal dominant hypophosphatemic rickets who have these mutations here. And this was by Michael Ekons and Eric Immel at Indiana University, where they showed in patients with ADHR that when they become iron deficient, they have much lower, when they become iron deficient is when they have higher levels of intact FGF23, which suggests that there's some alteration of the transcription and translation of FGF23, but in fact what they have, this is not true for control. So in patients with ADHR, it looks like there's some regulation of this process, post-translational modification by iron deficiency, that isn't seen in normal patients. But what we do see in normal patients is we have normal levels of intact FGF23, the more iron deficient we are. But what's happening is more FGF23 is being made, but more FGF23 is being degraded. It's a funny process. I'm not sure why this takes place. I can't teleologically explain this, but what it does show is that in ADHR, it's a disease of altered FGF23 processing, that FGF23 post-translational modification is regulated by iron, or probably EPO in this case. And it also makes the point, and we see this in other diseases as well, that post-translational modification is yet another level at which intact FGF23 levels can be regulated. Okay, so we won't, of course, be able to go into these, but these are pretty much most, if not all, of the diseases of FGF23 that we know at this time. So we talked about X-linked, we talked about autosomal dominant. There's other forms as well, McCune-Albright syndrome that we talked about. I did briefly want to talk about this. I wasn't initially, but these are some cases here from the University of Utah, and I thought I'd briefly talk about that. I'll get on a little bit into, we'll talk more about tumor-induced osteomylation, we'll talk about the treatment of these disorders, and I'll talk a little bit about renal failure, which is the FGF23 disease with the highest levels of FGF23. So just very briefly about cutaneous skeletal hypophosphatemia syndrome. So this is a disease that's caused by somatic mutations of RAS. So these are activating mutations of this RAS oncogene. They occur in a somatic fashion. Germline mutations would probably be lethal. And so depending where you get these mutations, this will determine the phenotype. So patients can have these, it's also called epidermal nevus syndrome, Schimmelpenning syndrome, we remember the name of yesterday, has a lot of eponyms. But anyway, so again, depending where you have the RAS mutation, if you have it in the skin, if you have it in the bone, you get this dysplasia. The dysplastic bone makes FGF23 as it does in McCune-Albright syndrome. And you can also get involvement in other tissues as well, a bone stem lipoma, and in this girl here, CNS melanosis. Part of the reason I mention this is there has been some debate as to whether or not the source of the FGF23 in these patients comes from the skin lesions or it comes from the bone lesions. To us, it made more sense that it comes from the bone. That's the physiologic source of FGF23. There's other bone disorders that have this as well, although there's been some old and not very good literature that suggested it come from the skin, and there have been efforts to try and decrease the FGF23 by removing these skin lesions, which in some cases, as you can see in this child, would be virtually impossible and actually pretty painful as well. Towards sorting this out, we've actually just completed making and are very early in the process of evaluating this mouse where we've put these RAS mutations into the bones of these animals. And depending where you turn that mutation on early in development, you can get a very profound disease as shown here. But if you turn it on later, you get a dysplastic bone disease that looks very much like that in the patients. These animals have high FGF23 and low serum phosphate, so we think that this really probably confirms that bone is the source of FGF23, and that should be the focus of the treatment and not the skin disease. Okay, so what are the broader implications of all this, what we've learned about FGF23 in terms of health and disease? And this is where we get into the renal failure story. So there, as you can imagine, there are many more patients with renal failure than there are with XLH or McCune-Albright syndrome, etc. And this was a work from a piece in the New England Journal from, when was this, 2008, I think? This was by Miles Wolfe and Orlando Gutierrez at Massachusetts General Hospital, where they looked at a large cohort of dialysis patients and looked specifically more closely at those patients in that cohort that had died. And they found in multi-regression analysis fashion that the levels of FGF23 appeared to be, at least by this retrospective analysis with multi-regression control, as much as that is possible, that FGF23 appeared to be an independent risk factor for mortality in these patients. And again, look at the levels of FGF23 in these patients. They're astronomically high. In patients with bad XLH, this might be 500. In these patients, it's an order of magnitude greater. But anyway, what they showed is that FGF23 exerted an independent effect on mortality. Work further in this area suggested that the nature of the mortality in these patients with the high FGF23 was not coronary artery disease per se, but left ventricular hypertrophy. So this appears to contribute to this, the left ventricular hypertrophy and congestive heart failure that renal failure patients get, not so much the cardiovascular disease. And there's been further animal work done to confirm this by Christian Fowl at the University of Miami, where they show by just treating mice with high levels of FGF23, they can recapitulate the CVH that those animals get with ventricular hypertrophy. This is not, doesn't require the Klotho co-receptor. It works through another FGF4 receptor, and this remains to be confirmed in humans at this point. So what does this mean? You know, what's then is the role of FGF23 in just sort of run-of-the-mill cardiovascular disease? And this is an area with a lot of debate, I think. This was one of the first papers that was published in this area. It was published in the Annals of Internal Medicine, a very reputable journal, of course. It was this heart and soul study from UCSF, 833 patients. And they looked at mortality in these patients. Again, this is a retrospective review, multi-regression analyses with multiple cofactors affecting this. And what they showed is that mortality and cardiovascular events in these patients was tremendously increased in patients with the highest levels of FGF23. Now, personally, I find this very hard to believe. Look at these levels of FGF23. So remember the levels in renal failure were 4,000. All of these are in the normal range. So this is a huge effect, a huge independent effect for FGF23. I mean, this is a more potent effect than hypertension, than hyperlipidemia, than smoking, et cetera, et cetera. So as I said, this is published. It's out there. It's an evolving story. If you look more closely at the one of the appendices that accompany this paper, where statistically all of these things with the red arrow were controlled for, the group of patients who had cardiovascular disease had more smoking, more diabetes, lower EGFR, et cetera, et cetera, et cetera. So it's just hard to believe, for me to believe, that all of these things were really controlled for that well, and these levels of FGF23 in the normal range exerted an independent risk for heart disease in these patients. But again, this is where the field is right now. It's an evolving story. And it's evolving pretty rapidly. This is just a quick slice of recent papers in this area. And I really don't know what's going on in northern Manhattan. They're having a lot of problems there. Talk about slicing the salami to get many papers out of one set of data. Anyway, so this suggests again that there's, and these are all retrospective analyses of these papers, of these populations, that there might be an independent effect of FGF23 on cardiovascular disease. I would say it remains to be determined. So, in moving on, I'd like to return to our case. The little Palestinian girl, she had 7 siblings, no consanguinity, no family history of rickets, no bowing short stature in the family. Her calcium was normal, her phosphate was quite low, PTH was normal, alk-phos was tremendously elevated, 25D levels were a little bit low, but her 125D level was very low, again consistent with an FGF23 disorder. So I did want to diverge while we're talking about her to talk about how you evaluate a patient with hypophosphatemia. And I think that this is a good way to do this. So you have a patient who has a low serum phosphate. You confirm that the phosphate is low because of renal loss, and you can look up how to do this. You calculate the TRP or the TMP-GFR. There's calculators on the internet. Just to confirm that the phosphate loss is from the kidney, it almost always is. And now you know that the defect is at the level of the kidney, and then you check the level of FGF23. If the problem is with the kidney, then the FGF23 level should be low, and you think about these disorders. These Fanconi types of tubulopathies that give you amino aciduria, proteinuria, bicarbonaturia. There's genetic Fanconi syndrome, and then there's the acquired type. So actually a lot of things can do this. Various toxins can do this. Lead, cadmium. There's a really interesting episode on the show House. I don't know if you saw this. There was a guy who had osteomalacia, and it ends up that he was smoking marijuana that he grew himself that was in cadmium-rich soil. So he had cadmium intoxication that was causing his tubulopathy. I thought that was a good show. Anyway, other drugs as well. Tenofovir, you really have to keep an eye out. This is being used a lot now as a prophylaxis for preventing AIDS. About 20% of these patients will get a tubulopathy, some with frank hypophosphatemia. But all of these are of the low FGF23 type. If the FGF23 is high, then we think of the genetic syndromes that we talked about, X-linked, autosomal dominant, autosomal recessive hypophosphatemic ricket, and then the acquired type. Tumor-induced, it's a short list, tumor-induced osteomalacia and metastatic cancers. This is never a mystery. These are patients who are dying from metastatic cancer, and they, oh, by the way, have hypophosphatemia, and their FGF23 is high. But this is the one that we're talking about here today, and this is the one that this young girl from Palestine had. So, yes, in fact, her tubular reabsorption was very low. We went ahead and ruled out by genetic testing that she had any of these known disorders, genetic disorders of hypophosphatemia. Some of these can present later in childhood and not so early. Her FGF23 levels were very high, so she had an acquired FGF23-mediated hypophosphatemia, TIO. Okay, so how do you evaluate and treat a patient with TIO? So this is an algorithm to do that. So you're looking for this little teeny tumor that can be anywhere. Probably the best study for this are DOTA scans. This is an FDA-approved isotope now. It's an analog of octreotide, the Octrea scan. This is the best single study for this. If you do this and you see one or multiple lesions, sometime the FDG PET scan can also help in confirmation of that. You confirm these little things that you see on these nuclear studies are in fact little tumors with CT or MRI. If you need to, selective venous sampling. If you get a catheter close to the tumor, the FGF23 levels are high. And if that's positive, surgical resection. What I would say about surgical resection, very, very important to do a wide resection. These tumors are not encapsulated. They often extend beyond where you think they are. And if you leave tumor behind, the disease is going to reoccur, and it does have some potential to metastasize. If this is negative, or if you can't find the lesion, then you're stuck with medical therapy. So what is medical therapy in this disease? Well, all of these disorders of FGF23 have the same medical treatment, whether it's XLH or TIO or CSHS. And the medical treatment is a pain in the neck, as the patients and the doctors will attest to. So you have to take oral phosphate, and you have to take this 3 to 5 times a day, and it tastes nasty, and it causes diarrhea. And the goal of this is, depending on the patient, is to try and get the predose serum phosphate to the low normal range. When you do this, it causes secondary hyperparathyroidism, so you also have to treat these patients with calcitriol. Calcitriol can prevent and control the secondary hyperparathyroidism. It probably improves the GI calcium and phosphate absorption. But the problem is with this is it can cause hypercalciuria. So now you have to follow the 24-hour urine very closely, and that can be an issue as well, because there's often iatrogenic nephrocalcinosis and nephrolithiasis in treating these patients. So you have to be careful. We talked a little bit earlier about cinacalcet. Cinacalcet is a nice adjuvant to this treatment. It can help because the FGF23 action is PTH dependent. It's an adjunct. But this too, as you lower the PTH, the urinary calcium can go up, and this can cause hypercalciuria as well. So again, it works, but you have to be really careful. You have to be really on top of it, and it's tricky. So we need better therapies, and fortunately it looks like there's a good therapy that's on its way. This is a monoclonal antibody against FGF23, so it blocks the interaction of FGF23 with the receptor. It's in clinical trials now for XLH, tumor-induced osteomalacia, and epidermal nevus syndrome. Short-term safety and efficacy look good, which is shown here. These are the early studies. These are the serum phosphate levels. So the drug is given once a month by subcutaneous injection. Very effective at maintaining the serum phosphate levels. Interestingly, we see this spike in 125D levels to supraphysiologic levels, which would be concerning because this might induce hypercalciuria. But here's the urine calcium in these patients, so it looks like this isn't going to be a problem. So this is an evolving therapy. It's late in development now, probably will be submitted to the agency soon, I would think. I think it holds great promise for treating these patients, and it'll certainly be a lot easier than the multiple drug therapy that they've had for years and years, and really represents the first new therapy for this disorder in 40 years. So it looks good. Okay, so we'll return to our little Palestinian girl now. And it was a little bit unfair because we actually did have a hint where her tumor was on physical examination. So in examining the mouth, we noticed this bulge in her mouth here, and we said, what about that thing in your mouth? She says, yeah, that started coming up a few years ago. She never paid much attention to it. Nobody paid any attention to it, so we thought that was interesting. So she had imaging studies. So she had a DOTA scan, which I talked about as a nuclear medicine study, and it suggested that there was something in this region in the mouth, and here's the fuse scan here. So this looked pretty good. She had also, because she was in a research study, also had an Actria scan where we were comparing these two modalities, and it showed up on the Actria scan as well. In terms of anatomical imaging, this is the CT scan on the left, and this is the MRI scan on the right. And again, she has this hypervascular lesion in her palate. You can see that on bony windows, this is not a soft tissue tumor, but this is sort of a bony tumor here. This probably arose from the bone cells, and the nature of these tumors is very interesting as well. Anyway, so this is where her tumor was. This was a tricky place to have a tumor because when this was removed, you're going to now have an opening into the sinus, and she'll need an obturator to seal the sinus off. She's going to have long-term protracted rehab after this. So where is she going to get this surgery done? So this was probably the most time-consuming part of her care, is getting a girl from Palestine to be treated in Haifa from the United States. So it required the cooperation of the Palestinian Health Authority, the Israeli Security Services, the U.S. federal government, and it took a long time. But we got her back to Rambam Hospital. It was one of the most satisfying things they ever done. It came together, the doctors from Palestine went to Israel to learn how to do the procedure. There were like 12 surgeons in the operating room, Israeli, Palestinian. There was an American surgeon there as well. She had the surgery there. She was effectively treated. And for the first time, and this was just a couple weeks after this, and she had been bedbound for years. She's up and walking. She's here with her father. She's back home, looking good. So very satisfying. That's the good thing about these TIO tumors, is when you find them and take them out, the patients are cured. So that's her story. Okay. So here's what we know so far. FGF23 regulates phosphate and vitamin D. It's made in bone. I didn't go into it, but has a pretty short half-life. Fortunately, the pharmacodynamics are pretty long, so FGF23 replacement might be a good therapy with patients with familial tumoral calcinosis. It's probably regulated by phosphate 125D, or it's some combination of that with calcium. That post-translational modification and processing is also a focus of regulation. It may have a direct effect on renal failure mortality, a cardiomyopathy effect, and it may play a role in non-uremic cardiovascular disease as well. So that's what we do know, and here's a very purposefully busy and confusing slide to show you all the stuff that we don't know. We talked about these diseases, autosomal recessive hypophosphatemia, X-linked hypophosphatemia. We have no clue what this gene DMP1 does. We have no clue what this gene FEX does, or ENPP1. We don't know how phosphate is sensed by cells. As you can see, there's a lot that we don't know. So there's really still a lot of work to be done in this area. This is my team of people who we work with in this area. It's a little bit of a dated picture, but these are most of the people. Bill Chong did a lot of this work. You saw his name. He's now at the FDA. Deanna made the mouse. Rachel Gaffney is the principal investigator on the FGF23 studies. Our wonderful surgeons who help us take out these. Richard Chang, an incredible interventional radiologist. Clara Chin in nuclear medicine. My nurses, who I owe everything to keep things together. And with that, I'll close and take any questions.
Any questions?
Thank you, Dr. Collins. That was eloquent and informative. So I saw that FGF, as you pointed out, is 23 is made in bone. So I assume there could be some other constitutional skeletal dysplasias that also alter FGF23. Perhaps maybe that's the mechanism for the Rain syndrome and the Janssen that you mentioned. Is that
Right.
Is that their pathogenesis, or they somehow affect the production of FGF23?
Right. So that table that I showed that had Rain syndrome on there, there are other disorders, skeletal disorders, that have altered FGF23 and phosphate levels, either high or low, some of whom we know the mutations for, and our understanding of those are evolving. So, for example, in Rain syndrome, there's a mutation in FAM20C, which is a kinase. So the story with the FGF23 and the glycosylation is even more complicated. So besides getting glycosylated, it also can get phosphorylated by this enzyme FAM20C. And it looks like if you get phosphorylated, then you can't get glycosylated, and FGF23 gets broken down. So it's a complicated and evolving story. But yes, you're right, there are other disorders as well. And I'm going to mispronounce this. The FGFR1 mutation disease with short stature, glyphonic dysplasia. What is it? You probably...
The osteoglyphonic dysplasia. I've never seen a person with it, but I've seen it on lists.
Yes. So yes, there are others, and it's interesting. I mean, like I said, this is an evolving story, which makes it fun and which makes it interesting. And it's clear these monogenic disorders have a profound effect phenotypically. So they all are going to play important roles in this evolving, complicated pathway that we're trying to look at. This point, I think I gave you what is all pretty certain and pretty clear. And so these other things will be for the next Marv Rollison lecture at some point. So.
You recommended using FGF levels fairly early on in your diagnostic paradigm there.
which I have not done, partly because I don't have good reference ranges.
Yeah.
If you were going to use FGF levels in pediatrics.
Yeah. So you raise a good point. FGF23 assays in 2017 are about at the place where parathyroid hormone assays were in 2000. This assay that you're going to send to Mayo or wherever to check FGF23, it doesn't distinguish between intact and C-terminal FGF23, so it sort of measures total FGF23, which there are important differences between the two. And so as a result, there's a really wide normal range. And so what it can tell you, though, is that if you have low blood phosphate, and if you have a low FGF23, or in fact if you have a normal FGF23, that's inappropriate. So a normal FGF23 or a low FGF23 is inappropriate in the setting of hypophosphatemia, and that probably represents an FGF23-mediated disorder. But you're right, it's an evolving story as well. I'm not sure why they don't offer the measurement of the intact FGF23. There are good ELISA kits for that. They're very good. They're not that expensive. Hopefully that will be coming as well. So it's something to keep an eye out for.
Hi there. I recently read a study about the Japanese researchers that I think you showed, it seemed like their names were similar, about the idea that the FGF could be coming from the skin and the cutaneous lesions, but that the technology wasn't present. Do you think that's possibly accurate?
I think it's probably not the case. So you're talking about these cutaneous lesions where the patients have low FGF23. High FGF23, low blood phosphate. And if you look back, and Diana Ovejero, who made the mouse, did this, you look back at all of the literature, go all the way back in the literature, and look at all the patients that have been described that have this. Practically every one of those that had the cutaneous lesions also had skeletal disease as well. The other thing, these cutaneous lesions, these cells derive from about 4 or 5 different cell types. And it's really hard for me to believe that all of these 4 or 5 different cell types would have a very different and separate origin and developmental biology. All of them somehow get to making excess FGF23. When in you and I, it's our bone cells that make FGF23. Towards that, and also too, we've taken these cutaneous lesions from patients with Schimmelpenning syndrome or Eppner-Nevis syndrome. And we've done very good studies. We've ground the tumors up. We've measured FGF23 in them, and there's nothing. We've done immunohistochemistry. We've done RT-PCR. We don't see any FGF23 in there. But we do see the FGF23 in the bone lesions from those patients, both by immunohistochemistry and PCR. And I think the best proof of this will be when we finish this work will be in this mouse model for when we put this mutation, this RAS mutation, into bone cells, and that perfectly recapitulates the disease. So I don't think it's the skin, I think it's the bone.
Any other questions? No? Okay. Thank you.